Good afternoon, ladies and gentlemen. It's my great pleasure to welcome you to the webinar organized by the European Reference Kidney Network, coordinated by Professor Franz Schäfer from Heidelberg. The topic of today's webinar is antenatal aspects of CAKUT and Ciliopathies, which will be presented by Paul Winyard from London, UK. My name is Elena Levchenko. I'm a pediatric nephrologist in Belgium, and I will moderate this webinar out of my office in Leuven. During the webinar, the slides will be presented on your screen, and you will be able to send us your questions using the special tab on your attendee panel. Questions can be sent anytime during the presentation and will be answered at the end of the webinar. The webinar will be recorded and the slides will be published on the website of ERKNet. This time you will have also some questions from the speaker to you, the polls, and you will be asked to vote. So this will be something new and very interesting. Let me introduce now in more detail the speaker of today, who is Professor Paul Winyard from London, UK. Paul's primary role are Professor of Pediatric Education in University College London and an honorary consultant in pediatric nephrology at Great Ormond Street Hospital and in fetal medicine at University College London Hospital. After medical school split between Cambridge for preclinical and Oxford for clinical, he trained in pediatrics in Charing Cross, Guy's, Oxford, Queen's Elizabeth Hacker and Great Ormond Street Hospital in the UK, and also did practice at Duke University and Philadelphia in the US. His first position at Great Ormond Street Hospital was in 1919, and he has worked in associated hospitals and universities ever since. He completed his pediatric nephrology training in 1999 and also finished his PhD on the molecular biology of renal malformations. Subsequently, he has committed clinical work in fetal medicine and polycystic kidney diseases, with research into renal development and stem cells. Paul is really passionate about medical education and runs both the Bachelor Science and Master Science programs in pediatrics and child health at UCL. So he is also elected as the president of the Academic Pediatrics Association in Great Britain and in Ireland this year in spring. So, Paul, we are really happy that you are ready to give this webinar. The floor is yours, and we are really eager to hear your talk, please.
Okay, thank you very much, Anna. Can I just check that everybody can hear me? Yes?
Yes,
okay.
Everybody can hear, but they cannot tell it to you, but I am sure everybody can hear.
Okay, that's perfect. Elena, thank you very much for that wonderful introduction. We'll start with my affiliations. I think you've actually given it. I'm employed by UCL and predominantly do education, but they give me a beautiful office. So if you look at the top of your screen, that picture was taken half an hour ago. It's a beautiful day in London, 22 degrees, glorious. So I do education at UCL, but I also work doing clinical work at Great Ormond Street. And pretty much all the work I'm going to talk today about antenatal clinics is done at UCL, so University College London Hospital, with a logo here. So thanks very much to ERKNet and all the organizers for asking me to talk. I'm conscious this is a very different subject to most pediatric nephrology. In fact, many of the people I talk to have had very little training. So what we're aiming to do, if I can get the slides to work, yes, is give a brief overview of CAKUT and then go through some cases. So different cases I've seen antenatally, and we'll think about what was happening at the time, how those patients were, or how the parents were counseled, and what happened. And at the end, I'm going to go through some important prognostic factors, because I think anybody can do antenatal counselling, but we're all very unsure about it. It's such an emotive area. So the overall aim of this talk is to increase confidence in counselling future families that you may see with these sorts of abnormalities. There are a number of cautions. I think most pediatricians are used to having a history of presenting complaint. They've got a child that's well, that becomes ill. They have medications, allergies, etc. Antenatal counselling is almost all but banned by ultrasound. That's all we have for ascertainment. So it's a scan done at usually 14 weeks or 20 weeks in the UK. Times will vary around the rest of Europe, but you get ultrasound information and very little else, maybe a tiny bit of family history. The thing that always strikes me with my obstetric colleagues is how obsessed they are with aneuploidy, i.e. major chromosomal abnormalities such as Down syndrome, Edwards, Patau, and things like that. Actually, when I show you some figures from our clinic later, you'll see why that is. It is actually very common. It's just something we don't see postnatally, because you can look at a child and say, that child is normal, that child has Down syndrome, but you can't get that information antenatally. And the other thing which is important, and I'll touch on this a bit later, is that actually, when you have parents with an abnormal child, they need to make a decision about continuing or not continuing the pregnancy, however one may feel about the ethics of that. But the problem is often you do that with incomplete information, because actually pathology will evolve over time. So something which may appear a little bit abnormal can become very abnormal later in pregnancy when it's too late, or something can correct during pregnancy. So there's that issue of time being both against us in several ways. So they're the cautions, that's the overview. Let's define CAKUT. So strictly speaking, CAKUT was defined in the 90s by Ichikawa when he was working in Nashville as congenital anomalies of the kidney and urinary tract. It's a huge spectrum containing everything from cystic and multicystic kidneys through to lower urinary tract dysfunction. Now, I have to say today, almost all the talk is going to be about cystic kidneys versus dysplastic kidneys, because I think that's what most nephrologists get called in to discuss. I suspect that the urologists will be called in to see valves and other lower urinary tract abnormalities. So we won't touch on those much today. And it's important, if you just look at the numbers, this is from the renal registry in the UK a couple of years ago, where it broke down the causes of end-stage renal failure in children. And if we just look at the numbers, the big numbers are renal dysplasia and obstructive uropathy. And these are little children. These are the children that are born with renal failure that sit on our wards for months and months and months, having peritoneal dialysis, having infections, having problems feeding. So that's 368 out of 702. So the most severe ones have renal dysplasia and obstructive uropathy. So it's an important condition. And probably nowadays, most of these will be diagnosed antenatally, and how little teaching most of us nephrologists have had in this area. So let's start with a couple of questions. I wanted to get a feel for how confident everyone in the audience is about making these diagnoses. And I can see some people like Juice too are probably very confident, but let's start with this question. How confident are you at antenatal counselling for CAKUT? So you give a number of answers. So 1, unsure, would always ask others. 2, depends on the case, but would be okay for some. 3, can generally give an informed view. 4, fairly confident in most cases. And 5, absolutely confident. So we can start if we can start that question, please. Okay, so can we see I guess I can see it there. So it looks to me like most people are in category 2. Depends on the case, okay in some, which I guess is fair enough. What I'm hoping is it will move everybody further down there, and we're going to ask this question again at the end. I have to say that my answer to this is 3.5. So I reckon I'm in between 3 and 4, and I've been doing this for 20 years. So if anybody answered 5, I think they're a bit overconfident. Let's move on to the next question then. So this is a test, isn't it? Because we actually said, how confident you are. So let's ask, what's the most important feature? So which of these is the most important for CAKUT antenatal prognostic counselling? So I want to tell these parents at 20 weeks, the outcome is good, the outcome is bad, or the outcome is somewhere in the middle. Which one of these is the most informative and most important? Okay, perfect. That's absolutely the right answer. I thought I would confuse you by saying amniotic fluid deepest pool. Actually, our center measures, sorry, excuse me, measures 4-quadrant amniotic fluid. Deepest pools is this the biggest one of those 4? This is absolutely right. We have no creatinine to measure. We have no other functional measures apart from urine output. From the second trimester, all the amniotic fluid, 95% of the amniotic fluid is urine output. So absolutely, it's our best indication of renal function. Other things we'll come into later on. Sorry, excuse me. So can we move on to the next slide? Right. One thing I want to talk about is this, and it certainly with my when you're writing a grant, you often say this is really important and give a figure. So when I'm writing a grant about this sort of thing, I'll say, you know, between 1% and 3% of antenatal scans pick up a renal or urinary tract abnormality, which is important because it clearly affects a lot of people. However, the vast majority are of no clinical significance. In fact, the commonest is very mild dilatation of the renal pelvis. So I don't even call it hydronephrosis because it's not pathological. In fact, one of the things about this is it has a major impact on the families involved. And I wanted to just think about that because in my sense, it's actually over-dramatized and makes too much of it, because this is what happens to the families. You know, they have an unexpected finding. Somebody does a scan. They say there's something wrong with the baby. Imagine this should be the happiest or one of the happiest days of your lives when you're going for your baby's ultrasound scan. Then there's something goes wrong, and they go through this typical sort of grieving process during pregnancy. Hope and acceptance, maybe it's not right. Then distance, denying, oh, I can't believe that's right. Let's get a second opinion, which my first case will demonstrate amply. Then grief and guilt. All mothers all feel they've done something wrong when there's something wrong with their baby, and it's mostly complete rubbish. And then desperate for proper medical guidance. One of the take-home messages for me from this talk is actually often I talk to when we do a monthly clinic at UCLH, where we get referrals from all over the north of London. So our catchment area is several million, and they say, even when I give them bad news, they say, thank you for giving me the true information and help me work through this. So they're desperate for medical guidance, and I hope this talk will help you do this for your patients in future. So these are some comments plucked from a psychological paper. And I want to give you 30 seconds to read this and put yourself in the situation of these poor mums, and actually dads clearly affected, who go through this situation. Okay, you'll get these slides at the end so you can look at these again. I think the one that really hits me is this one in the middle, which I hope you can see my mouse moving around. This is my last day as a happy pregnant woman. Now, that's a telling statement, isn't it? If there's something wrong with a baby. But actually, as I just said in the last slide, often we make a big fuss. We say there's an abnormality which is of no clinical significance. So we have to bear in mind that the cases I'm showing here are all significant, but actually a lot of cases have a ruined pregnancy with an insignificant malformation. So I think that's very important if you end up doing some of this counselling. And we need to think about this, which is abortion legislation in Europe, because actually it's the only time when parents, well, in fact it's mum that makes the decision, mum can decide not to continue with the pregnancy. And having had discussions with lots of people around Europe, I know the regulations are very different. But actually this adds an extra dimension to the timeliness. So in the UK, termination can be performed up to 24 weeks, really without at the mother's request. Usually beyond 20 weeks, then they wouldn't, centres won't do it unless there are major abnormalities. But I know in other countries you have different laws, but it is important to think about this. So it's a motive, and there's a time limit on when you can intervene. So this is very important. So let's move on to talking about the kidneys. this is the bit thing which gets me, and I'm going to present some of our data later about this, on large, bright kidneys. Often we'll get a referral, please can you see this lady, it's 20 weeks gestation, everything fine except large, bright kidneys. Well, what does it mean? Well, actually what it means is the echogenicity of the kidneys are greater than normal. And this is a scan. So this is a transverse section through the abdomen. This is the spine at the back, one kidney here and one kidney here. Now, these kidneys are actually bigger than they should be. They should be about this size. They should be about half that size, and they're very, very bright. So actually, if you look at kidneys, there's a spectrum like this of echogenicity. So some will be a little bit dull, most are normal, and you get this bit up here where some will be abnormal and some will be normal. And the differential diagnosis is huge. Again, I don't apologize for putting aneuploidy in here, as you'll see from my figures. This is something we don't think about after birth, but often you will find a major chromosomal abnormality. Normal variant. Sometimes we see that, sometimes we don't. And one of the keys there is how the disease progresses during pregnancy. Then the big ones, polycystic kidney diseases and various dysplasia syndromes. And this is what you need to make a decision on when you're counseling these parents. Is it a normal variant? Is it dysplastic kidneys as part of a syndrome, or just isolated dysplastic kidneys? Or is it polycystic kidneys? So this is what I always think when I see bright kidneys. And how do you then define which ones are likely to be abnormal? I think there are three things. I'm going to reiterate this all through the talk, which is kidney size. Is it normal? We have centiles for kidney size. Actually, very easy to remember kidney length, which is the one I usually go on, which is about 1 millimeter per after 20 weeks. It's about 1 millimeter per week of gestation. Kidney structure, does it have the normal corticomedullary differentiation, or have you lost that? So severely bright kidney will just be bright throughout without corticomedullary changes. And then, as we all identified earlier on, the amniotic fluid level as our only surrogate measure of function. So what we're trying to do really is estimate functional renal mass. So if you have a tiny, tiny, tiny kidney, it doesn't matter if it looks normal, because actually you won't have very much functional renal mass. However, often we're seeing very, very big kidneys, sometimes including cysts, and then it's difficult to work out how much mass there is that's working within that structure. So I'll show you some pictures in a second. So let's look at case one. And for those people who heard me talk before, I've been telling you about this case for 10 years because it's one of my favorite cases. It demonstrates the whole pathos and difficulties of going through this system. So this was referred to as at UCLH, a 21-week gestation because of potentially abnormal kidneys. It was actually the parents that pushed for this because the local department weren't sure. Both parents were alive and well, but there's a very traumatic and sad previous obstetric history. Firstly, they had severe renal dysplasia and agenesis in their first child, which they terminated, and not had pathology done, which is another lesson from this. Actually, if there is ever a termination, get the pathology to try and make the diagnosis. Then they lost twins because of twin-to-twin transfusion syndrome. So a terrible obstetric history. So reiterating the three things we need to look at: kidney size, kidney structure, and amniotic fluid. Let's look at their results. So this is a centile of kidney growth. In fact, this is not length, it's cubic centimeters, but the length would be similar. This is the 50th centile, 95th centile, 5th centile. So actually the kidneys, when we saw them first at 23 weeks, then we saw them again at 26 weeks, were pretty normal. Scan of the kidney. It's a bit more tricky, actually. There are bits here which are brighter than light, but we had a big discussion, and there were 3 of us in the room, and 2 of us said it was abnormal, 1 of us said it was normal. So it's somewhere between normal and bright. And then amniotic fluid. Again, centile charts, amniotic fluid, perfect. Okay, so when you're getting down to levels down here, then that's a worry. But actually here, it's well within the normal centiles. So we actually said, these parents have come from a long way, go back to the local, and we're happy to see you again if there are any issues, and certainly talk about the delivery. So this is what happened. Parents rang up because the local had said, oh, we're really worried about your baby. And in fact, it said, we're really worried your baby's going to die. and we have a great hospice at our hospital, and would you like to come and look around the hospice before the baby's born? So these are the findings: kidney size, kidney volume, both kidneys massively above the 95th centile. Scan of the kidney. This is not normal. There is no corticomedullary differentiation. There's absolutely no doubt that this is now bright, because if you look at this compared to the surrounding liver, it's bright. And then amniotic fluid, 0 amniotic fluid. So altogether, quite a terrible summary at that point. Kidneys were massive beyond the 95th centile. They were structurally abnormal, and there was no amniotic fluid. However, we were not as pessimistic as the local hospital, because you don't need your fetal kidneys for survival. Mom is the best dialysis machine in the world. Postnatal renal replacement is possible, as we know. And in this case, we knew that the amniotic fluid was normal up to 26 to 28 weeks. This is not just important because it gives an idea of kidney function, but it's also important for lung development. So normal lungs need to, well, basically the fetus breathes in amniotic fluids. There are growth factors in that, and we don't know what the growth factors are, in fact. Growth factors in that which help the lungs develop. So in fact, you're more worried at this point with no amniotic fluid about the lungs, but because it was fine up to 26, 28 weeks, we predicted the child would do well. So they transferred from the distant hospital to UCLH, premature labor, very soon after we saw them, in fact, 2.1 kilos, ventilated, went to Great Ormond Street, and this is her story from there on. Effectively, this is one of those children I talked about that are in your ward for months and months and months. Poor urine output, rising creatinine, and start on peritoneal dialysis at the end of the first week of life. Scans at that time confirmed big echogenic kidneys, but no cysts. So just think in your mind what the diagnosis might be, and we'll come on to that later. This is the prognosis. First 6 months, she spent 5 months in the hospital, very slow weight gain, had a nasogastric tube, as they all do. Parents refused a gastrostomy. By a year, still had the NG tube, had issues of peritonitis and occasional hemodialysis, but actually by that stage, more than half the time at home. And then 18 months, transplant with father's kidney, and eating it last. I have a good picture, which I haven't got time to show today, of her eating crisps or chips, as you might call them, because suddenly she wanted to eat that. So, diagnosis. I don't know if anybody came out with it. Actually, we don't know. So we looked at all the common genes, and she's been put into the 100,000 genome. And as far as I know, we still don't have an answer in this case. It must be genetic because of the previous history, but I'll report on that later. But what about her journey? What about the poor girl's journey and her parents' journey? Anxiety, uncertainty during the pregnancy, time commitment of actually having a family business that they both worked in, and one of them always in the hospital, family disruption, and a lifetime medicalization. Brilliant that she's done well with a transplant, but actually clearly she's still on medicalization. So this was one of the inspirations to actually go through our data, and this is an abstract which is going to be presented in Singapore next week from Angela Yulia, who's one of our obstetric trainees with the team, and myself at UCLH. So we looked at a 15-year retrospective review of all fetuses identified with echogenic kidneys. And over that period, we've got 316 cases. A lot of them didn't survive beyond birth. That's by both termination and death, so 105 terminations. And I'm going to give you some details on demographics in a second. So this is Angela's happily going off to Singapore next week while I'm sitting here until I go to San Diego. And these are the summary of our results, which we're preparing for publication at the moment. So let's just focus on the number column and the diagnoses. The other things take too long to explain today. Look at this, 316, 41 had aneuploidy. As I said, it's something we just don't think about, but that's more than 10%. Then we've got bladder obstruction with secondary dysplasia. So they have, remember these were reviewing echogenic kidneys. So in fact, bladder obstruction probably with secondary dysplasia, recessive and dominant polycystic kidney disease, and then this whole slew of dysplastic kidneys. 15 bilateral cystic dysplasia, 22 unilateral, and 18 of those. I'm going to rehash these figures later on. But that's just interesting, isn't it? That we see so many more of the bladder obstruction and dysplasias than we do of the polycystic kidney diseases, which most people think about. So, case 2. Referred at 21 weeks gestation, roughly the same, because of potentially abnormal kidneys. In fact, that's exactly the same presentation. Both parents alive and well, so no previous obstetric history of note. We saw the child at 26, 31, and 35 weeks. And kidneys grew and grew and grew. So they're growing to, but not beyond the 95th centile. Remember, the last one was massive. They were definitely bright with loss of cortical element differentiation, and the amniotic fluid fell to the 5th centile. By the 35th week, it was absolutely fine at the third. Well, it wasn't fine. It was on about the 10th centile on the 31st week. So actually, the lung development we find was slightly towards the lower end. So parents were anxious, transferred care to UCLH, but we said in this situation, actually, we don't know what's going on. The baby will probably be all right, but let's transfer to UCLH to make sure we have the neonatal support if needed. So what is the summary? Big kidneys, structure abnormal kidneys, reduced amniotic fluid, but all not as extreme as last time. And exactly the same stuff. Fetal kidneys not needed, postnatal renal replacement is possible, and novel amniotic fluid. So progress, this baby actually went beyond term. Parents were so concerned, and this is interesting because actually at no point had we said that the baby is going to have a problem or be at risk of demise. But parents were so worried about it, they had a priest in the delivery room ready to baptize the baby in case something did go wrong. However, the priest actually didn't need to be there because the APGARs were 9 at 1 and 10 at 5 minutes. Normal urine output, normal creatinine, kept in the unit for 3 days and then sent home. And it's interesting that despite the fact that they had a big, bright kidneys before birth, the postnatal scan was normal. It's one of those scans which says normal, but perhaps there might be slight changes. So it was iffy, but actually the major core was normal. And that's strange because actually sometimes you get that where we can clearly see abnormalities antenatally and postnatally they're normal. It's well reported in polycystic kidney disease. So this was actually 20 years ago now, where it was reported in polycystic PKD1, so AD-PKD. I've seen it many times with AD-PKD, and in fact with bright kidneys that come back as normal, but perhaps, and then will develop cysts later on. So what happened with this child? Well, upper normal limit of creatinine throughout. Formal GFRs 83, 75, and 73, so not normal, but not grossly abnormal. And the ultrasound showed progression of the disease. So there were a few small cysts and questionable corticomedullary differentiation. Again, it'd be nice for people just to write down what they think the diagnosis could be, because actually this is just a non-specific dysplastic kidney with perhaps a few cysts. So really, your differential diagnosis should be huge. This is taken from a paper about 2010, I think. So there are many, many more genes now which cause abnormal kidneys. Most of them cause other symptoms as well, or symptoms or signs such as limb abnormalities. In fact, the child had one of these. I'm not going to hold you in suspense because actually I've normally focused down on 4 different causes, and of these actually this one, TCF2 or HNF1 beta, is the one we see the most. And in fact, I'm not going to hold it back. This is what this child had. So the French reported many years ago that the anomalies of the TCF2 gene are the main cause of fetal bilateral hyperechogenic kidneys. And in fact, at Great Ormond Street, we looked at all our dysplastic patients and found, again, about a quarter of the undiagnosed dysplastic ones had HNF1 beta mutations. And they have a lot of other symptoms as well. Gout, one child I particularly remember, developed profound diabetes after transplantation, and we actually had to start him on sliding scale insulin because I guess he was pre-diabetic with this syndrome. And also they often will have a low magnesium and new mutations. So scanning of the parents doesn't always help. So in fact, that's what that child had, and any non-specific bright kidneys now, I think, should be tested for that. Case 3. This case was referred after the local 20-week scan, normal scan at 12 weeks, bright kidneys at 20 weeks, and perhaps a low amniotic fluid volume. Again, they're these things which sometimes people are imprecise. Oops, sorry, going backwards there, sorry. There was some history here of a miscarriage 8 weeks in the first pregnancy. However, actually, this is incredibly common. I think over half of pregnancy end with miscarriage before the 8th week. Mother and father well, no known renal history. So this is the scan at 23 weeks when we saw them. Large, bright kidneys, no cysts, normal amniotic fluid. So if I try and outline it with my mouse, this is the kidney here. It's a longitudinal view. And again, this is the spine in the middle, and there's one kidney here and one kidney here. Now, these kidneys are big, and they're a little bit bright. They're not massively bright, and there is still some corticomedullary differentiation. So this is what happened. Repeated scans about monthly. And actually, one of the things which we often seem to disagree with our American colleagues is that there probably is no reason to scan these babies any more than monthly, because there will not be a massive change. And it just, in my mind, induces anxiety. So repeated scans, large bright kidneys, no cysts, amniotic fluids always in the normal range. Born normally, no issues. And then 3 months, large kidneys, but no cysts. 12 months, 2 cysts on the left, 1 on the right. 3 years, big kidney with multiple small cysts, and one of those kidneys was 1.5 centimeters. So again, what do we think the diagnosis is? ADPKD. So in fact, scanning the parents, one of the parents had cysts, and actually we probably should scan all of the parents in these situations, because you find some unexpected answers, and they have classical ADPKD. Fourth and last case, and we'll come on to some diagnostic things and prognostic things after that. Referred in the 3rd pregnancy at 16 weeks with massive kidneys occupying the whole abdomen, and I'll show you those in a second, and oligohydramnios, so small reduction in amniotic fluid volume, but not anhydramnios. Past history, terminations at 24 weeks gestation and 20 weeks with similar history. And again, for religious reasons, no post-mortem performed on the baby, so no diagnosis made. Obviously, it's up to them to decide that, but I have to say, if parents are willing to have a post-mortem, it's very useful. You can now do high micro CT and slightly less invasive post-mortems where you take a bit of kidney tissue and make a diagnosis. In this case, parents had been scanned, and mom had 1 cyst on her left kidney, nothing else. Dad had normal kidneys. Difficult to know how to interpret that, because simple cysts develop as people get older, so we were unsure about whether that's important. This is what the scan of this baby showed. So this is a longitudinal view. This is the spine going down here. There's a ribs here. Here's one kidney. Here's the other kidney. These kidneys are absolutely massive. By far the biggest kidneys I've shown you today. And in fact, this child had ARPKD and sadly did not survive birth. In fact, you can see in this picture, there's virtually no amniotic fluid. So there's been a few publications recently, which I think several of the audience have actually been involved in. So this is a fantastic group put together by Franz Schaeffer to look at various renal conditions. This was published in JAMA Pediatrics last year, which Charlotte as the lead author, looking at follow-up and management of cystic renal diseases. And I think the key thing, which I always said when we're having a meeting to discuss that paper, is the classical polycystic kidney diseases do not have cysts before birth, or at least they don't have them early. The difficult time is around 20, 24 weeks. That's when you need to make those timely decisions. So in fact, if you took pathology of ARPKD kidneys, the cysts would be present, but they're too small to see by ultrasound, despite the fact ultrasound is fantastic. So what you see is loss of corticomedullary differentiation and slightly bright kidneys. You don't see cysts. ADPKD, I have to say, I've seen many of these, and the only time I've ever seen cysts is after about the 32nd week of gestation, when you start to get the occasional cyst. So effectively, if you get cysts at 20 weeks, or in fact, if it's unilateral, think dysplasia. So everybody's always focused. In fact, we nephrologists are always focused on polycystic kidney disease, but we're actually wrong most of the time. And in fact, I did a sort of back of the envelope thought on this about how often we should be seeing these. Okay, so there are the conditions down that column. This is the frequency in the general population: 1 in 1,000 for ADPKD, 1 in 20,000 for ARPKD, and something between 1 in 1,000 to 1 in 5,000 for dysplastic. It varies between conditions. But how many of them will present antenatally? So I reckon probably 5% of ADPKD, 90% of ARPKD, and 90% of dysplastic kidneys. So if you work the figures out, actually, antenatal clinic, 1 in 2,000, 1 in 22,000, 1 in, oh my God, I've got too many zeros there. Apologies for that. It should be again 1 in 20,000. So we should have probably 10 times as many dysplastic or dysplastic associated kidneys as we have polycystic. So going back to that survey, this is what we had. So in fact, in our survey of 316, we had 12 ADPKD, 10 ARPKD, and 97 dysplastic. When you add in the syndromes and the ones associated with obstruction, so that's about right. So you're almost 10 times as likely to see. Well, I guess if you put the two together, you're 5 times as likely to see dysplastic kidneys as you are polycystic kidneys. So bear that in mind, please. Going back to this is what we need to think about to make sure we're going to do this better in future. Always remember kidney size, kidney structure, amniotic fluid. And as I said, we're trying to think about how much functional renal tissue there is. And this is a nice way of thinking about that, which in fact, having done a PhD in developmental biology, when you look at the original development of the nephrons in polycystic kidney diseases, they're pristine, perfect. So nearly all normal tissues to start with, and then you get destruction of those tissues when the cysts develop. However, when you start looking at things like multicystic dysplastic kidney, it's never developed nephrons, so there's almost none from the start. Same with cystic dysplastic kidney, and you get more and more normal as you go through these different conditions. That's quite useful when you're looking at that functional renal mass. Where does it fit on that spectrum? And I use that to actually help with counselling. So we use this in the JAMA Pediatrics paper to think about it. So how do you counsel somebody? So if it's a simple cyst, you occasionally see one cyst, then probably doesn't have any significance. And you say, well, I expect your child's going to be normal, have normal kidney function, may need to have a couple of ultrasounds, but will be fine. However, if you've got big kidneys with bilateral cysts or just big bright kidneys, and you've got oligohydramnios, there's a chance you might get away with it. There's a very slim chance you might get away with just chronic kidney disease. But actually, your spectrum of outcome is likely to be here in this range, from dialysis from birth, dialysis in childhood, to actually, sadly, perinatal death because of respiratory insufficiency. So I hope that's quite a useful way of thinking about counselling. More data on our findings, PKD, etc., is in this article which we just published last month. And I said the 316 cases we're just writing up, and hopefully that will get submitted in the next 2 or 3 weeks when Angela gets back from Singapore and I get back from San Diego. One thing I use in teaching is this. I have an Excel spreadsheet which will generate random combinations of these. How it actually doesn't work as well as the old-fashioned system I developed, which was actually, I don't know if anybody knows what a tombola is, where you pluck out numbers. So, well, like lottery, in fact. So I have 5 different cups, and I put each one of these in. So I might put a gestation in one cup, and you pick out one of them. You pick out the kidney size out of another cup, the appearance of the kidney in another cup, and the amniotic fluid out of the 4th cup. And the 5th one is whether it's unilateral or bilateral, which I haven't put in here. But that's quite good, isn't it? Because you can actually think, what if I pick out a 28-week gestation, the kidneys are on the 95th centile, the amniotic fluid is below the 5th centile, and the kidneys are very bright or possibly bright. I hope you'll know now that actually that's likely to be a poor outcome because of the big bright kidneys and the low amniotic fluid. However, because it's 28 weeks, we don't know what the amniotic fluid was before that, we can't predict how the respiratory function will be. Similarly, if you get 36 weeks and there are many cysts but a normal amniotic fluid, actually it's probably a cystic dysplastic, but which will not have immediate issues, or it may be on the rare occasion ADPKD. So that's quite useful. And I can send people the CAKUT, the Excel generator, if people think it would be useful. So conclusions. Antenatal diagnosis is difficult. It's much more difficult than having a child in front of you having that battery of tests. It's poorly taught, And counselling is emotive. I'm often getting very emotive when I'm talking to parents, as clearly they are. Many normal kidneys are now being picked up, and I feel that is sad. In fact, sometimes I think actually you need a fetal medicine unit to actually reassure parents more than to tell them about the bad cases. Always think about that normal versus dysplastic versus polycystic. Use the 3 indicators I've talked about, which are size, structure, and amniotic fluid volume. And remember that actually most of these conditions are developing. So pathology and radiology develops over time. The classical issue being the AD-PKD, where they don't have cysts at 20 weeks, but they may have cysts at 32, 34 weeks. So in a nutshell, the importance of this. Experienced teams, we know about known unknowns. So we know that those bright kidneys might develop cysts later. We know that amniotic fluid might fall. We're there to counsel parents and try and avoid the severe parental distress, which is natural when you're told that your baby in the womb maybe have a problem. And I think in terms of preparedness, we have a system where any child that's likely to have renal or respiratory compromise gets transferred to our centre. And as I said, we have a huge catchment area, so they'll come to our unit, which is used to these situations, and we can be better prepared. So, Tanya, I don't know if we can do this again. Can you pop up that question for this one? So this is our first question about how confident are you at antenatal counselling? Oh, I think it's a bit better. I think it is a little bit better. We'll have to look at those results later, but I think we've moved slightly down there. Let's move to the next question. Now, I haven't done my job, and I should probably sacked as a professor of education if we don't get this one right. That's not that's not an incentive to write the wrong answer, by the way. Yes, perfect. However, I have actually tricked you with this question, which is actually probably the most important prognostic feature overall, is whether they've got other abnormalities. Now, I haven't talked about this, but often we'll find babies that don't just have kidney abnormalities, they've got heart abnormalities or brain abnormalities. And in fact, so probably for their overall prognosis, that's more important. But since this is a talk about CAKUT, we're just focusing on isolated CAKUT. So sorry to trick you on that. And of course, I don't counsel. Presumably, you wouldn't counsel on that. It would be the obstetric and the fetal medicine people who are involved in that counseling. So thank you very much for listening, and let's have a few questions. And I just wanted to announce the next webinar, which is on November the 6th, when it's Rachel Lennon from Manchester and Jaap Groothoff from Amsterdam talking about microscopic hematuria. Thank you.
Thank you very much, Paul, for this really wonderful presentation, clearly showing how it's still difficult to counsel these patients. And I think your CAKUT case calculator is very nice. It can be a very useful tool for us. I only did not see actually whether in your CAKUT calculator it was indicated whether the anomaly was bilateral or unilateral. Is it included in there?
That's I didn't write that in there because it gets too complicated. But okay, actually, it is in the Excel spreadsheet. The problem with the Excel spreadsheet is that sometimes it works, sometimes it doesn't. So I thought I'm not going to show it today. I'm sure somebody who's smart at doing that thing can actually generate a proper one, not in Excel, which we can use. In fact, it'd be really useful because there are many combinations. But it'd be nice to have a sort of set counselling that we'd use in the variation of that sort of graph of the spectrum, which I presented earlier on.
I'm sure that people will be eager to make an app from that so that it will go on a mobile device or the computer. So let's go on with the questions. There is a question to thank you from Caroline Mayens, and there is a question whether you perform next generation sequencing or whole genome sequencing antenatally? And if you do so, how best to do this? Actually, there's a question about genetic diagnostics in this patient, when to do antenatally or postnatally, and whether it's useful.
Yeah, so the answer is because of funding, we don't do that usually, unless there are clear things. So what we've done traditionally is look at the individual genes. So, for example, TCF2, HNF1 beta sending off to Exeter, which is the centre in the UK. They're changing that now, and the 100,000 genome project, I think, is changing. So a lot of our patients have been put into the 100,000 genome because congenital or structural abnormalities of the kidney were part of that. It's been going on for the last 2.5 years. We're starting to get results back. I've seen 2. I think I've sent about 10, 12 patients. I've seen 2 back, one of which came up with a known gene. The other one came up with nothing. So in the UK, we're a bit behind because of costs. But I think actually when we get all of the 100,000 genome results, and there's a lady called Melanie Chan who's doing a PhD at the Royal Free into all the CAKUT results. So I think in maybe a year, well, probably by the time they'll come back, 2 years' time, we'll know the answer about whether it's useful or not. At the moment, we don't tend to do that unless there's an obvious reason. And actually, the side point of that was that actually when I started doing this clinic, it was with a duly qualified obstetrician and fetal medicine person called Lynn Chitty, and she has pioneered doing free fetal DNA tests. So this is where a blood sample is taken from mom, but you then look for abnormalities in the fetus, and that's really actually changed our practice because we used to do amniocentesis all the time, looking for genetics. Now we use free fetal DNA, and that's again something which is at the moment only available privately outside research, but I think will come into practice. So we will start doing that, and it's brilliant because it's not invasive. Take a blood sample from mom, and we'll hopefully get results.
Yeah, this is very, very nice whenever it will be available. I had maybe other people would like to ask questions. I see that 45 people are listening, so please don't be shy and just write your question and send it.
The other thing, actually, while we're waiting, I was going to say the other thing. I noticed that Juice Shanstra was on. I don't know if you got the ASN Juice, but we should talk about this. But with our 316 patients, we've actually developed a scoring system now where we're scoring all the different factors and predicting outcome on the basis of the scoring. There's still a bit of maths to be done on that. But if anybody's got big groups of patients that have similar appearances to this, it would be really good to get together at the ASN or whenever and actually apply our scoring system and see if it works.
Yes,
giving a different ranking for the different features.
So this is also good that just you need a validation cohort where you can validate your scoring system. Yeah. Okay. So Lisa Mirror also does thank you. Everybody apparently liked your seminar. Can I ask you another question? Whether in your scoring system there is an indication where the prognosis is really very poor, which might be an indication for the termination of pregnancy. I can imagine that this is a delicate question which can be differently approached in different countries, but in the UK working culture, are there some indications of for termination of pregnancy that you can, agree based on this scoring system?
Well, we haven't applied the scoring system to yet because we just developed it over the last 2 months. In the UK, as I said, actually you can have a termination almost at mother's request up to 24 weeks. That's the law, but in fact, very few centres will do that really beyond 20 weeks now because the method of termination. And I sound like I know about this. I don't know about it because in fact the obstetricians do all the counselling and all the procedures. So I've just been in discussions with them. After 24 weeks, if there is significant risk to the mother's health, or the child may have a severe life-threatening malformation, then they can still terminate the fetus. That requires the signature of 2 obstetricians, one involved in the case. Actually, it doesn't have to be involved. One who's not involved in the case, and another one, which will usually be the obstetrician. So, of course, I never get involved in signing those. It's always the obstetrician. I know it's much more strict in many other countries.
Mm-hmm. Yeah. So thank you for answering this. There is another question whether it is important to try to get into environmental factors during the pregnancy, which can be involved in the developing of this kind of anomalies.
Yes, absolutely. So there's some great work done by Nina Neurs and Kristen Renkomer in Holland about this, and doing environmental surveys, and I think it does have an effect. So the interesting thing is that many of my colleagues are geneticists, and they believe that everything is genetic, whereas I believe there's an element of chance and lots of things like tiny exposures in the environment, whether it's to vitamin A, whether it's to toxins, whether it's to drugs, which may or may not be in the drinking water. I think that these things summate. So I think that the classical geneticist believes that in 5 years' time we'll know the cause of all these because everybody will have genetic mutations causing it. I don't think they're right. Even now, less than 20% of cases, when they've done huge systematic reviews, less than 20% of cases seem to have a genetic etiology. And that may be because we don't have the maths to deal with having multiple different small effects from genes, or it may be because there are other effects like the environment. Yeah.
I think it will be our last question. There was a question about the usefulness of fetal cystoscopy in patients with low urinary tract obstruction. It was not really the topic of your talk, but maybe you can comment on that.
But it's very interesting that, because the places that do it are great proponents of it and say it is fantastic. And there have been, certainly over the last couple of years, some papers on that saying it's technically possible. And it is technically possible, but there's not enough data out there, I think, to really know about long-term outcomes. And if you think about the data on shunting, that everybody thought 20 years ago that shunting was the answer. We shunt everybody, and then we will save all these babies. Well, actually, the proof, as far as I read it on shunting, is that actually what we do is we help them survive, probably because of respiratory effects, but we don't have a meaningful impact on the renal function. So these babies that have had shunts still have terrible renal function and still need dialysis. And I suspect that technically, even though they can do cystoscopy and ablate valves and do some fantastic things early in gestation, it's not early enough, because just because you start with one nephron, well, one branch of the ureteric bud, and then you get consecutive doubling of the number of nephrons. So if you take out a large proportion of the early gestation, when they should be doubling every day almost, you knock down the number of nephrons. So even if you can do it and give a chance to recover, it will not recover back to normal.
Okay, thank you very much for these clear answers. And at the end, I would like to thank you for the very good presentation, the audience for listening and for asking questions. And please join us on November 6th for the next webinar given by Rachel Lennon and Jaap Kroto. Thank you very much. The webinar will be closed. Thank you.
Thank you.